I would like to thank the organizing committee uh, for inviting me to give this lecture. And today I'm going to talk about the treatment of high-risk neuroblastoma. The high-risk neuroblastoma treatment can be divided into different phases, so including induction, local control, treatment of persistent disease, consolidation, and maintenance. And I will go over it one by one. First, let's talk about the induction. And there are different chemotherapy regimen being adopted by different center. And one of them is called rapid Kojak. And rapid Kojak was originally developed by the United Kingdom, and the initial Kojak treatment basically is composed of alternate cisplatinum and carboplatinum backbone. But in rapid Kojak, the main thing is that instead of the usual 21-day cycle, it's given in the 10 days cycle, as illustrated here. And so, with such a frequency of cycle, in fact, the patient may not have enough time to recover from what we call the neutropenic phase. So, but interestingly, with this particular rapid Kojak cycle, most of the patient, in fact, are not too much immunosuppressed. Another protocol is called the N7 protocol. So it's originally designed by the Sloan Kettering group. So modified because initially in the original design, it was given at 7 course, but subsequently they find that quite a number of patients developed secondary leukemia in the form of AML. So they shortened the treatment into 5 courses. And this the characteristic of this particular protocol is that it's alternating what we call the CAV, which composed of the cyclophosphamide, adriamycin, and vincristine, and cisplatinum and etoposide. Another main feature of the modified N7 protocol is the dose that they give in terms of cyclophosphamide, doxorubicin, and vincristine, etc., are relatively high and intensive. So modifications of the N7 protocol is the COG protocol. So instead of using the CAV up front, they use the topotecan cyclophosphamide, 2 courses as the initial therapy. The good thing is after these 2 courses of cyclotopotecan, then they can harvest the peripheral blood stem cell for the subsequent auto transplant. And because relatively these 2 courses of treatment are not too myelosuppressive. So there's a question as of whether those patients still with a persistent bone marrow disease will compromise the outcome of this patient if you harvest the PBSC that early. But in their study, it doesn't seem to matter. So after these 2 courses of chemotherapy, then they adopt the cisplatinum and VP16, then followed by the CAV, as in N7 protocol, but now you can see it's a reverse order. Another features of the latest design of this study is that if the patient has persistent disease, they will use systemic MIBG and try to clear up the persistent disease. And also another feature they are trying to test currently is the use of the tandem transplant, which I will allude to later on. So the German also have their own protocol, and basically they have what they call the N5 cycle and N6 cycle. So the chemotherapy they use are actually quite similar to the rapid Kojak and also the N7. And, it also contains the doxorubicins like the N7 protocol. And also the high dose therapy, they use the CEM, carboplatinum, etoposide, melphalan, which is similar to the COG protocol. So on top of this intensive chemotherapy regimens, the SIOP PODC committee actually come up with a modified protocols for the developing country, mainly because if the treatment is too intensive, many of the patients may suffer a mortality due to infection, etc. So they use a similar chemotherapy backbone like the cisplatin, etoposide, cyclophosphamide, doxorubicin, etc. But in addition to that, so it is quite similar to the N7. They lower down the dose of each of the chemotherapeutic agents each cycle, so that the patient will not suffer as much. So in summary, for the induction is all the current chemotherapeutic regimens usually has less than 8 courses of treatment. So the additional chemotherapy does not seem to have additional advantage, but with more side effect, just like what the N7 protocol showed that they will have more therapy-related AML. The patient with persistent disease has to be treated with other strategy, which I will allude to later on. And the SIOPN has done the upfront comparison, a randomized trial, comparing the rapid Kojak and N7, and find that actually they are equally effective, but the toxic profile is different. It seems that the rapid Kojak has a less toxic profile in terms of infection, myelosuppression, and GI toxicity. So that's why the standard of care for the SIOPN right now is to use the rapid Kojak. Then we go to the local control. So for this species line, I think the most important thing is this report from the SIOPN study, is that if we can perform a complete macroscopic excision, what we call a CME, as compared to those with incomplete macroscopic resection, actually we find that those with complete resection has a better 5-year event-free and overall survival as compared to those with incomplete resection. And at the same time, if we look at the local progression, that means a local relapse or persistent disease, actually the patient with this complete macroscopic excision actually again has a much lower local progression or relapse with or without this immunotherapy. How about the local irradiation therapy? Is it really necessary? So let's look at the figure F and G here. So both of these diagrams show you the local regional failure-free survival. So the orange one is the one with irradiation, and the blue one is the one without irradiation to the tumor bag. So the difference between the F and G is that F show that the difference of this RT effect if the patient has more than 90% resection, whereas in the figure G is less than 90% resection. And in both situations, local RT can give a much better local control as compared to those patients without local irradiation. So now we know that both complete macroscopic resection and local RT can minimize local relapse and have a better long-term event-free and overall survival. How about those patients with persistent disease after we give this induction therapy? So some of the study try to add on additional therapy, like in the SIOPN, they add on this topotecan, vincristine, and doxorubicin. So, and it was found that this additional course of chemo, usually they give 2 additional courses, will improve the response rate. But interestingly, there's no impact on the long-term event-free and overall survival. So we have to look for other strategy to get rid of this persistent disease. And one of them is this MIBG. So MIBG is a specific target tracer that can go to the neurological origin kind of tumor, like neuroblastoma, pheochromocytoma, or paraganglioma, etc. So this early study by Dr. Maffei is that basically was shown that the systemic MIBG can give an overall complete partial response rate to maybe around 36%. And the toxicity, especially in the hematological system, is around 33%, and some of them subsequently require auto transplant to support it. So this is one thing we have to be careful. So if in case we perform this MIBG treatment, beware that maybe 1/3 of the patient may subsequently need to be rescued by auto transplant. So whereas the toxicity of the other organ systems, such as the liver and the lung, is not actually that high. But another interesting thing is, despite the survival advantage initially, both in the UN phase overall, but subsequently many of patients still relapse. So this is not the final treatment of the patient. Another modality is to use the lutetium-177 dotatate treatment. So as you can see, this study from the UK, the toxic side effect actually for the myelosuppressions and the kidney is not that much. And then the patient can give a reasonable response after 2 to 3 cycles. Mm-hmm. And then basically, most of the patients cannot achieve complete remission, but may have an interval improvement in the response, such as we saw in the two picture here before and after. And this kind of finding has been verified by the Australian group. And then as you can see, it can actually help to reduce both the extent and also the size of the metastatic lesions, but not necessarily a complete remission. So in short, the treatment of persistent disease, if in case we try to utilize more courses of chemotherapy, may not affect the outcome. The use of I-131 MIBG or lutetium-177 DOTA treatment, and both of them may also improve the remission rate, but they have to be followed up by additional therapy in order to improve the survival, because both of them seldom achieve complete remission for patients with persistent disease. So how about the consolidated treatments with auto transplant? So basically in this meta-analysis, as using the data of the German and the US data, and then you can find out that the patients in general may benefit from having this auto transplant after megatherapy. But which particular preparatory or conditioning regimen is best for the patient? In this particular study by the Cyalpen group, it was shown that the busulfan melphalan, the blue line, seems to achieve a better event-free and overall survival as compared to carboplatin, etoposide, and melphalan conditioning. But of course, the COG group comment on this particular finding is because the efficacy of such a conditioning regimen may reflect the effect of the induction therapy, because in the rapid COJAC, as adopted by the Cyalpen, basically they utilize carboplatin and cisplatin as the main backbone for the therapy. So the addition of carboplatin in addition may not help the patient. So what is the side effect of this busulfan melphalan combination? Actually, in the Cyalpen experience, around 11% of the patient may develop renal occlusive disease. That's also the experience in the Hong Kong group. Out of the around 30 patients underwent this transplant, around 4 patients developed VOD and 1 with hypertension. And Julie Park from the US actually tried to examine the effect of tandem, that means double transplant, for the patient with metastatic neuroblastoma. And it was found that overall, it can improve the survival, especially for patients after the transplant will receive the immunotherapy. So both the event-free and also overall survival show that the tandem transplant arm perform better than a single transplant. Finally, we will go to the targeted therapy with anti-GD2. So this diagram, using the B cells, anti-CD20 as an example. So how did this monoclonal antibody work is that actually, other from direct effect, the antibody can trigger the complement to punch hole on the cells, causing complement-dependent cytotoxicity. And in addition, it will also link up the macrophage and also the NK cell to the tumor cells through the FC receptor, and then subsequently target at this, for example, neuroblastoma cells or B lymphoma cells. So the NK cell will secrete the ganzyme and perforin and then kill the cell, whereas the macrophage will just phagocyte the target cells. So, and I think most of us are familiar with this famous study done by Alice Yu for the COG group, and basically combine the anti-GD2 with the GM-CSF, IL-2, and all-trimethylic acid for the treatment of metastatic neuroblastoma. It was clearly showed that those patients who received the immunotherapy will have a more superior, around 20% additional benefit in terms of event-free survival. And Lai Kang in this single-center study also showed that another anti-GD2 antibody, the VF8, and actually together with the GM-CSF will improve the survival. So as shown in this study, those patients only receive the antibody or an antibody through the intravenous route or the antibody through the subcutaneous route, and then find that actually those patients who has the antibody with the GM-CSF through the subcutaneous route has a much better survival. And this benefit also can be demonstrated in patients with ultra-high risk group patient. The anti-GD2 therapy, in fact, also being verified by the Sarpen high-risk treatments, and showing that with the addition of this immunotherapy, the survival of the patients is in 5 years is around 60%. And we also find that similar. We are in Hong Kong, we are one of the few centers in the world that has the experience in using both the VF8 and the CH1418 CHO. So this is a much longer study because the earlier study, if you look at 4 to 5 years event-free survival, so it's maybe around 50%. And then the Sarpen study, also if you look at the 4 to 5 years event-free survival, it's an overall survival is around 50%. So actually, they have quite a similar overall survival by either one of the antibody. And concerning about the cytokine, because both GM-CSF and IL-2 has been adopted by the COG study, But in the Siopen, they shown that the additional of this IL-2 together with the NDGD2 doesn't seem to have added benefit to the final outcome. As you can see, the survival line basically overlap. So in summary, for the NDGD2 therapy, it can improve the survival from 20 to 30% to 50 to 60%, and the additional of GM-CSF to the therapy, but not the IL-2, can enhance the cytotoxicity of this NDGD2 to the cancer cell. Pain is an universal experience, but seems to decrease with time. The long-term infusion, that means over 16 to 24 hours, in fact can minimize the pain sensation. In our local 30 patients treated with this 614-18 6-0, only 3 of them developed anaphylaxis. So this may be around small proportions of them, and then they can be managed conservatively. Whereas all the other side effect probably does not related to this NDGD2. So, but in the whole Siopen cohort, in fact, there are 4 cases of neuropathy in terms of transverse myelitis or the Guillain-Barré-like neuropathy, and one of them was irreversible. So, and other things that now we know that the NDGD2 treatment does not pass through the blood-brain barrier and seems cannot prevent the CNS relapse. Finally, the latest development is that there's a new generation of ALK inhibitor, the lorlatinib, and because the ALK amplification and mutation combined is found in around 13-14% of the patient. And then this is the first time that the Siopen and the COG group will combine and try to look at the efficacy of this lorlatinib together with chemotherapy on this particular group patient. So I would like to thank all these organizations, hospital and NGO in helping us to take care of this group of challenging patients. Thank you.